Medurstand. Understanding medicine.
I am Professor Aziz-ur-Rehman, and today we are going to discuss this condition which is apparently very common but not well recognized. And this is androgen deficiency in aging men. Now, just a little disclaimer that this condition is different than true hypogonadism, which could be due to pituitary disease or due to disease in the gonads, which are of course very well known conditions. But this is a relatively a newly recognized condition which has got very subtle symptoms and often goes undiagnosed. Before we discuss this condition, the clinical feature, the laboratory abnormalities, let me first explain the way normally our testosterone is regulated. This is hypothalamus, this is pituitary, and these are testes. Now, you know the ultimate regulator is hypothalamus, the brain, the lower part of the brain, and that regulates the body and especially our hormones through the pituitary gland. And in this case, hypothalamus secretes what is called gonadotropin releasing hormone. Now, gonadotropins are released by the pituitary, and there are two gonadotropin. One is follicle stimulating hormone, the other is luteinizing hormone. And in case of testosterone, luteinizing hormone is the main hormone which stimulates production of testosterone. So you can this is the axis. Hypothalamus tells pituitary to produce gonadotropin, and that is luteinizing hormone that stimulates testes to produce testosterone. Testosterone level will rise and it would have inhibitory effect on the pituitary. This is an excellent negative feedback system. All hormones have this system. So once the hormone is in sufficient quantity, due to this negative feedback, the further production of stimulatory hormone is suppressed and testosterone is regulated within a certain range. So this is actually a very excellent and almost perfect system. The problem could be here. The pituitary may not produce sufficient luteinizing hormone. That would obviously result in reduced production of testosterone. And this would be called hypogonadotropic hypogonadism, because the actual problem is deficiency of gonadotropin. And the problem may be in the testes, like in testicular failure, testicular atrophy. So if that is the case, testosterone will be low, but that would the inhibitory effect on the pituitary will be lost and gonadotropin will be high. And this condition is called hypergonadotropic hypogonadism. So these are two broad categories. Sites of androgen action. Androgen is a steroid, and all steroids have intranuclear receptors, and they are present almost everywhere in the body. Our brain cells, our skin cells, muscle cells, heart cells, liver cells, all bone cells, and bone marrow cells, all cells have these androgen receptors. That indicates that the androgen probably has action everywhere in the body, not just the sex regulation. Now these intranuclear receptors are stimulated, and that leads to production of appropriate proteins which regulate our body, which executes effect of testosterone. Now because this is intranuclear, so the effect would be slightly delayed and it would be also durable, unlike those hormones which act on the receptors on the surface of the cells. The distribution of testosterone in the body, most of testosterone, and just take the example of young people, the testosterone is distributed in three parts. This big chunk is bound to sex hormone binding globulin. Now this testosterone will be measured when we measure total testosterone, but this one is functionally inactive. It is not available for body action. Now then we have albumin bound. This is available but not immediately. the one which is immediately available is the free testosterone. So you just notice that free testosterone is only very small fraction of the total testosterone in young people, and in elderly, number one, just note that the total testosterone is reduced as compared to this pie. This one is much smaller. Another thing which is even more interesting, that this sex hormone binding globulin portion is further increased. So the inactive form of testosterone in elderly is even further increased, and the total is reduced, the inactive form is increased. So the fraction which is metabolically effective is very significantly reduced. So this is normal physiological aging. So that is why elderly people have reduced testosterone, and particularly testosterone action. Now, as we advance, testosterone level reduces. It is almost a part of aging. Uh, we are referring to a condition which has got multiple terms. Now let me explain. First is androgen deficiency in aging men. This is abbreviated as ADAM. Now I actually have used this terminology in my presentation. Others are age-related low testosterone, ARLT, or andropause as compared to menopause, or menopause. Just this is with MAN, referring to the equivalent of menopause in women, and penopause. This is a little funny, and I'm sure you can figure out what it means. Male menopause. So these are various terms which are used, or simply low testosterone. Since we avoid using this word testosterone, at least people they do not feel very comfortable using this word. So low T syndrome is another term which can explain this condition. But I have used this word, a term androgen deficiency in aging men. Now let me give you a comparison of menopause and the ADAM. Menopause is ovarian failure, which is very well recognized condition, and that occurs in women. And then we are going to compare it with ADAM, which is a relatively less well recognized condition, and this is a condition which occurs in men. Now this is the hormone in female at the level of at the age of puberty. Suddenly the estrogen progesterone level increase, and this is because there is increase in gonadotropins. So first there is increase in gonadotropin, that leads to increase in estrogen and progesterone, and throughout the menstrual life till there's menopause, there's almost abrupt drop, and that leads to almost abrupt symptomatology. Of course, one symptom is loss of, the periods are stopped, menstruation stops, but there are other symptoms, they also occur rather abruptly. Now, as compared to that, in men, the start is the same, and then throughout the youth, the hormone level is maintained. But you notice that in there is rather gradual drop in testosterone level, and this drop starts before that happens in women. This is typically 50-55, and testosterone stops declining in mid 30s. So around the age of 35, this level starts dropping and gradually drops. So it does not make a very sharp curve like the estrogen in menopause. So that is why the symptoms are not very abrupt. Now this would lead to sexual dysfunction, hypogonadism, that physical decline, because testosterone has effect on the muscle, and men have more muscle than women, primarily because of the testosterone effect, and psychological changes also. But these changes are often attributed to simply aging, and they are not typically linked to testosterone. Now, a clinical features may be summed up in this cartoon which is going to appear, and this is actually a joke. Way back when I was a student, one of our teachers told me this joke. And this is, you can figure out, this is men's sexual health, uh, daily, weekly, and then weekly. So I guess you know what I mean. So this is actually one of the manifestation of andropause. Uh, Menopause is basically an ovarian phenomenon. Ovaries, they stop producing estrogen and progesterone, and it is usually abrupt, and that results in amenorrhea. So amenorrhea is the manifestation of menopause. Uh, and those women who had their hysterectomy, they would also have menopause, but of course they already have this amenorrhea, they would have other symptoms. So it is primarily ovarian failure. So this would be hypergonadotropic hypogonadism like condition. Uh, it's primarily ovarian failure, estrogen and progesterone is not produced. So inhibitory effect on the pituitary will be lost, and follicle stimulating hormone and luteinizing hormones are actually increased. So compared with this condition, Adam, it is primarily hypothalamic phenomenon. So it is the reduced production of gonadotropins from the hypothalamus and the pituitary. It's a very gradual, and there's nothing equivalent to amenorrhea, so we cannot recognize that Adam has started. And it is hypothalamic, and FSH and LH are normal or maybe low, but they are not high. So compare it with the menopause. So they're two different conditions. They're not exactly equivalent. The prevalence of Adam is in 5 million Americans have this condition, and more interesting than this is that less than 5% are currently treated. Now, this is because of the taboo. People do not discuss this issue with physicians, or physicians do not encourage this discussion, or they don't realize that there is a problem. So that is why this condition remains undiagnosed or untreated. Now, this is a very uh, I think interesting thing, that only 5% is apparently a treatable condition. Less than 5% people are treated. Uh, this is the normal aging phenomenon. There is an evidence, and this is a journal, this was study published in 2001, how normal people, normal men have decline in testosterone as the age advances. Now these are various age groups, 20 to 29, 30 to 39, and you can see this different. And there are two types of measurement. One is the total testosterone. If it is less than 11.3 millimoles, that would be considered testosterone deficiency. And then there is free thyroxine index, which is calculated by dividing total testosterone by sex hormone binding globulin. These days we can actually measure free testosterone. So please note down that as age advances, the prevalence of hypogonadism, ADAM, androgen deficiency in aging men increases very sharply. Now, either way, if you use free thyroxine, free testosterone as a criteria, uh, more than 94% people would have androgen deficiency when they are 80 plus. So that means it's like a regular feature of aging. So very high prevalence in elderly. What are the possible effects? Adam has got a systemic symptomatology because, as I said in the beginning, this androgen has got receptors everywhere in the body. So the symptoms are also likely to be wide. So there is baldness, and there's a typical pattern of baldness called male pattern baldness, and there may be sarcopenia, the muscle mass is reduced, and the skin fat is increased. Bone mineral density may also be reduced, and there may be testicular atrophy, and there may be thinning of the skin. There may be, because of relative excess of estrogen, there may be gynecomastia, and even cognitive function may be impaired. Since testosterone has got wide actions, so it has got wide symptomatology. These are very vague symptoms, so it is really not possible to pinpoint the possibility of ADEM because these are very, very vague symptoms. Now, how do we evaluate? First of all, we have high index of suspicion, and then we have clinical evaluation, then we have laboratory evaluation, and then we give treatment. So let me give you an outline of evaluation. First of all, who needs to be evaluated for possible ADEM? I think any man with vague sexual or systemic symptoms above 40 and a person where these symptoms cannot be attributed to another known disease. If that person has got chronic liver disease, chronic kidney disease, COPD, heart failure, then of course we can explain these symptoms on the basis of that disease. But if somebody does not have any such disease but has got vague sexual or systemic symptom and he is above 40, I think we need to suspect this condition. Just 40, at 40, most people consider themselves as very, very young, but you could suspect this condition at this age. Now, this is a questionnaire as developed by St. Louis University, ADEM questionnaire. There are 10 questions. I'm going to read them out. Do you have a decrease in libido? Do you have a lack of energy? Do you have a decrease in strength and or endurance? Have you lost some height? Have you noticed a decreased enjoyment of life in general? Are you sad and or grumpy? Are your erections less strong? Have you noted a recent deterioration in your ability to play sports? Are you falling asleep after dinner? Has there been a recent deterioration in your work performance? So these are 10 questions. If the answer is yes to 1 or 7, question number 1 and 7, because these two questions are directly related to sex life. Do you have a decrease in libido or are your erections less strong? If answer to any of these two is yes, then this person qualifies for further evaluation. Or if there is yes to 3 other questions, so I think that person would also qualify. We haven't yet made a diagnosis, but this person is likely to have ADEM and needs further laboratory evaluation. And what is the laboratory evaluation? We measure testosterone, but important thing is since like many other hormones, testosterone also has a diurnal variation. So I think it is best that we take morning sample and we must repeat it twice, maybe 2 or 3 weeks apart before we make a formal diagnosis, because one lab test value may be high or low for some condition which cannot be accounted for. We measure total testosterone, which of course include all 3 portions: the free testosterone, albumin-bound testosterone, and sex hormone binding globulin bound testosterone. So that will be measured, and along with that, I think sex hormone binding globulin and PSA should also be measured. Why sex hormone binding globulin? Because we would like to calculate free testosterone index. PSA, because once we start treating these patients with testosterone, we would like to monitor his PSA. So we like to know the baseline. Of course, if somebody has very high PSA, that person should be investigated for possible prostate cancer, and that would probably constitute a contraindication for testosterone treatment. Now, free testosterone, the question mark means that the assays are not very well standardized. It is available, but it's not available in all labs. If your laboratory is doing free testosterone and your laboratory is standardized, maybe you can go for free testosterone. Of course, this would have a better correlation with symptomology and will give you a better diagnosis. But if that is not available, then we can measure total testosterone, and using sex hormone binding globulin and using the formula we can calculate free testosterone index. FSH and LH are generally not measured when we suspect ADAM, but when we suspected hypogonadism otherwise, then of course FSH and LH would be measured. Now, how to interpret? There is a wide range. Now, that makes it little difficult. Now, if you compare it with like calcium range or potassium range, they have very narrow range, or pH. So these things, they have very narrow range. Any level which is beyond that narrow range is easily interpreted as high or low. But when it comes to hormones, particularly testosterone, the range is very wide. So the range would be typically from more than 300, from 300 to say 1200, like that. And we must interpret the lab report in the proper perspective. Now, if we are already suspecting ADAM on the basis of St. Louis University criteria, then of course any value here would be interpreted as low. Now, there are three possible categories. One is sufficiency. Now, this is like vitamin D. If the testosterone is above mid normal, that would probably mean that the symptoms are not due to testosterone deficiency. This person has enough testosterone. And if they're below normal, then of course again the diagnosis is very easy. A patient has symptoms and testosterone level is below normal, it is definitely a case of ADAM. But then the most difficult situation is this one. Patient has symptoms, testosterone is not below normal, but it is in the lower 1/3. So I think these patients may be labeled as having insufficient testosterone, and if their patient have symptoms, maybe they can be given a trial of treatment and see how these patients respond. So we have three categories: sufficiency, deficiency, and insufficiency. These two, I think, would lead to clear clinical judgment. This one may be difficult if patient is symptomatic. Like I said, must interpret in the proper perspective. In a symptomatic person, this may be taken as androgen deficiency. Treatment. I think there are some natural ways to boost testosterone. Maybe one can try these. Good fats. We always condemn fat because they have a lot of calories. They can lead to hyperlipidemia. But these days we have started realizing that fats are not too bad. Only excessive consumption of fat may be bad. So good fats, the fats which come from fish, from nuts, and from vegetables, they can be consumed. And weight management, if you're overweight, that would obviously kill your sex. So I think you need to manage your weight. Carbohydrates should be reduced in quantity, and adequate nutrition, especially vitamins, vitamin D, zinc, and magnesium, they have been shown to improve sex. They can be taken as vitamin supplements, or they can be taken from the natural source. Avoid stress. It may not be easy or it may not be possible at all, but one should try to avoid the stressful activity and avoid smoking and drugs and avoid medication. There are many medicines. Actually, this is very unfortunate fact. There are many medicines which are prescribed for other reasons. They can reduce your androgen level. And one such example is metformin. Many people have diabetes and they are prescribed metformin, and metformin is known to have anti-androgen effect. So if possible, maybe one can try to avoid that medication, but of course your physician will tell you. Now, what is the plan? Overall plan is, first of all, we have clinical evaluation. We listen to patient's story. We put him the questionnaire. Now, if patient qualifies, and then we do laboratory evaluation. On the basis of these two, we make a plan. We discuss the pros and cons of testosterone replacement therapy, because people are still very skeptical about testosterone. So I think we need to discuss pros and cons. In a person who has definite deficiency, I think pros will clearly outweigh the cons. So if the patient agrees to try, then we give a treatment trial, and after say 3 months, then we re-evaluate. Again, re-evaluation is both clinical as well as laboratory. Now there are three possibilities. After this, one possibility is that there is clear-cut clinical improvement, and testosterone, which was in the lower range or below normal, that has normalized. So I think this makes very good sense. Patient, the symptoms have improved and testosterone has been normalized, then I think the best outcome is to continue testosterone, because this patient now has ADAM. For how long? Difficult question at this moment, but of course for a long term, very long term. Another situation is no clinical improvement, but testosterone level is also still low. That means maybe we are not giving enough dosage or patient is not absorbing. I think in this case, I would like to increase the dosage and repeat the same trial after another 3 months. And third possibility is there is no clinical improvement, whereas testosterone has become normal. Now, in this case, I think the best outcome would be to stop testosterone and look for another cause. So, of course, the judgment would vary from person to person and from physician to physician, but this is the general outline of the treatment plan. The concerns about testosterone replacement therapy, abbreviated as TRT. Number one, BPH, because testosterone is stimulus for prostate growth. There is general thinking that if we take testosterone, there would be increased chances of BPH, but that is not true, because we are giving testosterone only to those who have testosterone deficiency. Prostate cancer, and scientifically we know that once somebody has prostate cancer, testosterone can actually increase its growth, and the treatment of prostate cancer includes anti-androgen therapy. So of course, if somebody has prostate cancer, we should never give testosterone. But if somebody does not have prostate cancer, no study has yet confirmed that giving testosterone would increase his chances of developing prostate cancer. So we need not worry. Liver, the old preparations, if given orally, they have been shown to increase hepatic cholestasis. But the new drugs, they are probably safe from this side effect, because they are made in a way that once you take this testosterone preparation with meal, they are absorbed through lymphatics. Being fat-soluble hormones, they are absorbed through lymphatics along with fat. So if something is absorbed through lymphatics, it would not go to the liver, it would go to the systemic circulation. So liver would not be bombarded with high testosterone coming from the gut. So chances are that very few patients will develop liver toxicity, and that is actually the case these days. Even if you take testosterone orally, there are extremely low chances of developing liver toxicity. Cardiovascular, because estrogen has shown increased risk of DVT, but that is not applicable to testosterone. Lipid level, if anything, there is improvement in lipid profile. DVT, no effect on DVT. And infertility, of course, testosterone would suppress spermatogenesis. So it would actually cause infertility. But of course, we are talking about an age group 40 plus, where fertility is usually not a major issue, because most people, they have completed their families before that. But of course, if fertility is a concern, then giving testosterone is going to reduce fertility. It is going to reduce spermatogenesis. Now, benefits of TRT, what should patient expect? I think there may be some improvement in libido, because testosterone works through brain also, and there isn't much effect on erectile function, but luckily we have alternate treatment for erectile dysfunction. So maybe we can give testosterone to improve libido and the other medication to improve erectile function, to improve one's sexual health. Muscle and bone strength may also be increased, and there may be improvement in well-being. There may be improvement in metabolic profile also. Lipids typically come down, glucose also come down, and CVS, there is neutral effect. So these are the benefits of, but in some parameters there is actually the benefits on cardiovascular. I'm going to show you another slide which has got very impressive results. Now this is that slide. Now see, these are study which was published in JAMA in 2017. Not very old. Now they compared people who were never given TRT and with those who were given TRT, and they measured cardiovascular events. This column indicates the number of events, and this is the event rates. So if you compare, and these are, now this please again, this is a group TRT never, and this is TRT ever. Now see, stroke, which is a cardiovascular phenomenon, 3.1 versus 2.1, 2.7 versus 2.2. Let me say the other way actually, 2.1 versus 3.1, 2.2 versus 2.7, 11.9 versus 18.2, and 4.7 versus 6.3, 3.4 versus 5.7, and 2.4 versus 3.3, and 1.5 versus 3, and 16.7 versus 23.1. So all cardiovascular events, stroke, TIA, cardiac event, acute myocardial infarction, need for revascularization, unstable angina, death, all-cause death. So all were less in those who were ever given TRT. Now, if you see the p-value, all p-values are quite low. So all these findings are significant findings. So that makes a strong case of TRT in people with andropause. Now, this is another meta-analysis of 75 randomized controlled trials, benefits and risk of TRT. Now, these are the parameters: mortality, coronary artery disease, severe coronary artery disease, carotid intima thickness, fat mass, glycemic control, and total. Now, out of 75, 46 studies showed benefit. See, very impressive. 46 showed clear beneficial effect and none showed harmful effect. Very encouraging. 46 out of 75 studies showed, and these are randomized controlled trials which are considered to be very reliable. So 46 out of 75 studies showed beneficial effect and none study showed harmful effect, although 29 studies were neutral. They did not show any benefit or risk. So overall, there is benefit. How do we treat these patients? What are various formulations and precautions? Tablets, testosterone is available in tablet form. I think it's a 40 milligram tablet, 1 to 2 tablet given twice daily with meal. Now please note down, this is to be given with meal because fat is absorbed and fat soluble vitamins are absorbed. Anything which is fat soluble will be absorbed with fat, and fat absorption is activated with meal. And you need to watch liver because although I have given you a very strong reassurance that the chances of liver toxicity is very low, but still I would like to watch liver function test. I think maybe we can do ALT before we start testosterone, and then we can do ALT again after every 3 months. Then depot injection, oil-based 250 milligram intramuscular once fortnightly. Although we do not know exactly what frequency of testosterone administration would be right. Some people they need every week, and others they may not need for 3 or 4 weeks, but average frequency is fortnightly. And gel is available. It can be applied on any part of the body, and since uh, if somebody else touches the body, there is a possibility that that person would also absorb some androgen. So you need to watch the companions, and of course if the companion is a woman, that is the natural companion. So if there is a woman can of course develop some androgen effects, that has to be watched. Buckle, not very popular. And then we have pellets, the small pellets which can be injected subcutaneously every 9 months. Apparently an attractive option, but this involves injection, so many people would not probably like this, although the compliance will improve because you have to go to the hospital, have the injection, and that will be good for 9 months. Let me compare various treatment options. We have injections, we have oral tablets, and we have topical gel. Now, injection is once fortnightly, and it is painful because it is oil based. It has to be given into the muscle, and it is painful. And a wrong technique, non-sterilized, wrong technique, and if you do not follow sterilization, it could lead to abscess formation. Then there's roller coaster effect, because uh, anything which is given fortnightly, there will be time when the level is high and there will be time when the level is low. So there may be a roller coaster effect, and the cost is very low. I just made these calculation in local currency, and for monthly cost, it is just 500 rupees. Compared to oral tablets daily, once a day or twice a day, 1 to 2 tablets. And compliance issue, because if somebody has to take pill every day twice, then there would be compliance issue, but the effect is uniform. If somebody takes it every day, the effect is likely to be uniform. Liver side effects you of course need to watch. The chances are very low, and the cost is fairly high, almost 3 times the cost of injection. In our country, cost is a big consideration, so I think there are other considerations, but cost has to be considered also. Topical gel, daily, once a day or twice a day. Then compliance issue with gel also, and there may be again uniform effect, and there is a companion issue, but the cost is very high. Average cost would be even 3 times the oral tablets. So tablets are 3 times more expensive than injection, and gel is 3 times more expensive than oral tablets. So based on this, you can decide, and of course, there are patients where cost is not an issue, so then you can offer the convenience of gel and tablet. But there are people who can't afford money, and then you can offer the benefit of cost with injections. Big gap between theory and practice. And in my first or second slide, I showed you that only 5% Americans with low T syndrome with andropause are getting treatment. And this is because of lack of awareness. People do not know that this condition exists. Unfortunately, many physicians also do not know that this condition exists, and then taboo. People do not feel comfortable discussing these issues. Then there is general hormonophobia. People are scared of taking hormones. People think that taking hormone is major interference with body metabolism. So people are generally afraid of taking hormones. Now this we're coming almost to the end of my presentation. The summary: first of all, accept Adam as a reality. I have shown you different slides, and there is very high prevalence of low testosterone. I showed you that after the age of 80, more than 94% people would have androgen deficiency. Get out of the delusion that mard kabhi booda nahi hota. Those who do not understand Urdu, this is an Urdu word, there is used to be a saying that a man never gets old, I mean referring to the sexual function. But of course we have to accept that men also get old and their sexual function decline. Keep a high index of suspicion in 40 plus or 50 plus males and investigate if indicated. First of all, questionnaire, then testosterone assess. Discuss benefits and risk of TRT with patient, and if you counsel him properly, most probably patient will like to take a trial, and once patient takes a trial, then of course further decision will be made on the result of the trial. And we discussed after 3 months trial, if patient improves, the symptoms improve and testosterone level is also normalized, then the treatment should be continued. If symptoms do not improve and testosterone level is also still low, then we try a higher dose. And if symptoms have not improved but testosterone has become normal, then probably we should look for another cause for the symptom. Treat patient, not the lab value. This is the general rule. We should always try treat the patient. We must interpret the lab values with proper perspective. If patient has sex-related or systemic symptoms compatible with andropause and there is low T, only then we should treat these patients with testosterone. These are the references. This is the New England Journal of Medicine, which is very trustworthy, very credible journal, and effects of testosterone treatment in older men. This is another one, risk of testosterone replacement therapy and recommendation for monitoring. Still another one, Annals of Internal Medicine, efficacy and safety of testosterone treatment in men, and evidence support for a clinical practice guideline by the American College of Physicians. Further references you can find, and if you're interested, this is the website which gives summary of many new studies and recommendation. If you're really interested in this topic, you can access this site. This is free and you can learn more. And then of course you can learn more on my channel called Medurstand. This has been Professor Aziz-ur-Rehman from Medurstand. It was pleasure talking to you, and I really look forward to see you in my next video. Thank you very much.